Good afternoon, everybody. My name is Joshua Hare. I'm the Louis Lemberg Professor of Medicine. It's my pleasure to welcome you to the 34th Annual Miriam Lemberg Lectureship in Cardiovascular Medicine. This, as I've just told you, is 34 years old now, so we're very proud of this lectureship. It is one of the key contributions of cardiology to the Medical Grand Round series. And it has a very exciting history. When the Louis Lemberg endowment was being developed, led by Miriam Lemberg, Lou was quietly working behind Miriam's back to develop an endowment for this lectureship. And we're very fortunate that both were successful, and we now have this long-standing lectureship that has brought the most important cardiovascular physicians and scientists from around the world to lecture to us. We're very pleased to have Lou Lemberg's daughter here, Paula Saltzman, and her family. And with that, I'll turn it over to introduce our speaker, Milton Packer.
Good afternoon, everyone. My name is Darius. I'm one of the chief residents. I'm here to introduce our Grand Round speaker today, Dr. Milton Packer. Dr. Packer is a distinguished scholar in cardiovascular science at Baylor University Medical Center at Dallas and visiting professor at the Imperial College in London. He is an internationally recognized clinical investigator whose work over the last 50 years has fundamentally changed our understanding and management of heart failure. In 1992, he proposed the neurohormonal hypothesis for the mechanism of heart failure with reduced ejection fraction. And in 2025, he proposed the Adipokine hypothesis for heart failure with preserved ejection fraction. Dr. Packer has led over 20 large international clinical trials, including the landmark Copernicus and Paradigm HF trials that demonstrated the efficacies of carvedilol and valsartan sacubitril in heart failure treatment, respectively. His contributions to the field of cardiology have earned him multiple awards, including the Lewis Katz Lifetime Achievement Award from Columbia University and both gold and silver medals from the European Society of Cardiology. Today, he will be speaking on the Adipokine hypothesis of heart failure and a preserved ejection fraction. Please join me in welcoming Dr. Milton Packer.
Well, thank you so much. I am so delighted to be here. It's been a wonderful visit starting from last evening. I want a special thanks to the Lemberg family for making this possible. You're not making a lecture possible. You're making a visit possible. Visits are very different than lectures. Lectures, I'm going to speak for an hour. Visits, you speak for hours and hours, and you get to know people and you form relationships, and it changes everyone. So my sincerest thanks to you for making this possible, because visits are much more important than lectures. I told you how unimportant this lecture is going to be. And so I have a goal in this lecture. And my goal in this lecture is not to teach you anything. My goal in this lecture is to change how you think. If I change how you think, you can teach yourself. But if I don't change how you think, then nothing I say will be remembered by anyone here. So the entire concept of this idea, heart failure with preserved ejection fraction, is actually a reasonably new concept. When I started in heart failure was heart failure with a reduced ejection fraction. Almost everyone had it. Heart failure with preserved ejection fraction hardly existed. When I hired Matt Moore, who subsequently became world famous in his work in amyloid heart disease, and I said, I want you to work on heart failure with a preserved ejection fraction, he said, where am I ever going to find the patient? And now it has become the most common phenotype of heart failure. So when we think about heart failure with a preserved ejection fraction, what I'd like to do is exclude a number of diseases that are not HFpEF, not true HFpEF. Cardiac amyloid, valvular diseases, hypertrophic infiltrative cardiomyopathy. These are what are referred to as HFpEF mimics. Maybe 20, 25% of the population of HFpEF. Very important to exclude them because they have different mechanisms, they have very specific treatments, and people benefit when they are treated with those specific treatments. I am going to be talking about the top part, which is true HFpEF. And if I were to ask you what you thought caused true HFpEF, you would give me some variation of different potential causal factors on this slide. You can read them for yourself. There are thousands of papers in the literature saying that each one of these is mechanistically meaningful and drives the development of HFpEF. And the total amount of evidence to support that belief is 0. But that is current dogma in the field. Let me remind you that it used to be that HFrEF, heart failure with a reduced ejection fraction, was also thought to be phenotypically heterogeneous. It is. Different manifestations in different people. But it is not thought that any of these represent causal mechanisms that represent treatable pathways. Instead, in HFrEF, we have a unified hypothesis that neurohormonal activation, neurohormonal imbalances drives the development of HFrEF, sympathetic nervous system, renin-angiotensin system, aldosterone, neprilysin, and that all of these are just downstream manifestations of heart failure with a reduced ejection fraction. It doesn't matter which one of these you have, you treat the disease the same way. So the question that arises is, could that be also true for HFpEF? Now, again, you read the literature, and the literature will say, oh no, HFpEF isn't one disease. It's dozens of diseases, hundreds of diseases. So many diseases that we don't know how many diseases because we don't even know whether what we're saying is true. So let's assume that there is a unified hypothesis. What would that look like? What would be the upstream mediator of HFpEF? Well, there is something that's pretty obvious. Remember, I told you when I first started, there was very little HFpEF. And HFpEF has reached epidemic proportions. Hypertension hasn't changed. Coronary disease hasn't changed. One thing has changed in the last 30 years, which is that we have lived through the most dramatic epidemic of obesity ever. Not just in North America, but throughout the entire world. And so you begin to think, are these two related in some way? Well, I don't want to use the word obesity. It's a terrible word because it's based on body mass index and it doesn't distinguish different types of adipose tissue. There's subcutaneous adipose tissue, which is biologically dormant. And then there is adipose tissue around the key organs of the body, the heart, the kidney, the mesentery. It's referred to as visceral fat. It's biologically completely different than subcutaneous fat. And we don't measure it by body mass index. We measure it sort of okay with waist to height ratio. Your waist should be about half your height. If it's more, you have central adiposity or central obesity, as some people would use. Again, I prefer not to use the word obesity because it is so influenced by bone and skeletal muscle and not by adipose tissue. So could visceral adiposity be the unifying hypothesis for this big epidemic of heart failure with preserved ejection fraction? Well, visceral adiposity is influenced by age. We get more of it when we're older. Sex, women have a lot more than men. Diet, for certain. Genetics, absolutely. And all of these factors impact not only on the mass of adipose tissue, but on the biology of adipose tissue. And all of these adipose-related biomarkers are linked to all of the downstream mechanisms and phenotypes that you see in HFpEF. So the hypothesis is that all of these phenotypes are not causal. They're just all related to one upstream mechanism, and that's an excess in visceral fat, a biological transformation of visceral adipose tissue. So how do we know that that might happen? Well, we can measure visceral adipose tissue by imaging. We can do it in the abdomen. We can do it around the heart. Regardless of how we do it, it precedes the development of HFpEF by years, 10, 15 years. Adipose tissue, visceral adipose tissue accumulates, and it predicts only HFpEF and not heart failure with a reduced ejection fraction. And there are Mendelian links that have been established of visceral adipose tissue and HFpEF, not with HFrEF. And when you finally get established HFpEF and the patients are enrolled in trials, central adiposity is present in almost everyone. This is from our Paragon study. You can look at BMI. It was increased in about half the patients. Central adiposity was present in 96% of patients with HFpEF. And what was really amazing was that not only in Paragon, but in another trial, large-scale trial, the greater the waist-to-height ratio, the greater the risk of heart failure events and cardiovascular death. So there's a really strong predictive value of visceral adiposity with the development of HFpEF and the progression of HFpEF. And if you look at all of the pathophysiological and endocrine abnormalities in people with obesity and patients with HFpEF, whether you're looking at inflammation, if you're looking at left ventricular structure and function, whether you're looking at blood volume, blood pressure, neurohormonal activation, the overlap between these abnormalities in patients with obesity and HFpEF is enormous. It's almost as if almost every patient, if long enough would develop HFpEF. And almost every patient with HFpEF has preceding visceral adiposity. So we have some close links. These are epidemiological links. We have Mendelian randomization studies, not only showing a link of visceral adiposity and HFpEF, but visceral adiposity and diabetes and hypertension and chronic kidney disease. And we have all of this really intriguing information. And the question is, why hasn't anyone mentioned this? And the answer is, they have. Both the American Heart Association, the American College of Cardiology have recognized visceral adipose tissue excess as the proximal igniting influence for cardiovascular kidney metabolic syndrome, and particularly HFpEF. And if you look at the scientific statement of the American Heart Association, HFpEF is at the bottom, visceral fat is at the top. The fat becomes expanded, becomes dysfunctional, and causes all of these downstream effects. So you might think, well, with all of this recognition, then this relationship should have probably been well known and obvious. Well, that assumes that people read these statements, that people remembered what they read, that people talked to other people who said, did you see that statement on visceral fat and HFpEF? And the other person would say, yeah, I saw that statement. Isn't that interesting? Those are the discussions that create the percolation and transmission, dissemination of ideas. Didn't happen here. Not because the relationships were not recognized, but because they weren't transmitted. So let's assume that this is correct. Let's assume that the epidemiological relationships are right. How does that happen? How does visceral adipose tissue, when it is expanded and inflamed, how does that cause HFpEF? What is the mediator? Well, it is well known that adipose tissue is the largest endocrine organ in the body. Largest one in the whole body. It's an endocrine factory. It's a paracrine factory. It makes thousands of signaling molecules. And they're so incredibly dominant because 30% of your body weight is adipose tissue. And if you have obesity, 45 to 50% of your body weight is adipose tissue. This dwarfs every other endocrine organ in the body. Adipose tissue makes molecules, signaling molecules. They're called adipokines. They can be of a variety of different types, and they are transmitter molecules, messengers. They signal to the rest of the body, to every organ, what the state of adipose tissue is. And the signals are very, very, very straightforward. If adipose tissue is happy, the body's happy. If adipose tissue is miserable, it will make the rest of the body miserable. Adipose tissue is the energy transducer from the environment to external environment to the internal environment. So adipose tissue makes healthy adipokines to maintain a healthy body, makes maladaptive adipokines to create disease states. So many disease states are due to chronic obesity and adipokine imbalances, and the heart is particularly sensitive to the effects of these adipokines. These adipokines, by the way, come in various forms. Some of them are proteins, polypeptides. Some of them are bioactive lipids, microRNAs, inflammatory cells. They can signal in various ways. The signaling is concerted, it's programmed, it's orchestrated. It is not random. And so the adipokines are a very viable possibility that they mediate the effect, mediate the relationship of visceral adipose tissue to heart failure and a preserved ejection fraction. So the adipokine hypothesis, applicable to most people with HFpEF, is very straightforward. If you have excess visceral fat, it becomes biologically transformed. It alters its synthesis of adipokines. When this becomes maladaptive, it produces systemic inflammation. It injures the heart, the kidney, and causes HFpEF by promoting left ventricular filling and impairing the ability of the left ventricle to tolerate filling. And is this a common disease? It affects millions and millions of people, and it is growing every year. So I spent the last 7-8 years trying to make sense of all these adipokines. There were so many of them. And there were a handful of people who were focused on the adipose biology, but there was no connection between the adipose biologists and cardiologists or those involved in any other subspecialty. And so in a recent paper, I proposed that you could make sense of these adipokines if you put them into 3 buckets, 3 domains. Domain 1 were cardioprotective adipokines. These are healthy adipokines. These are adipokines that are anti-inflammatory, they're natriuretic, they're cardioprotective, they're increased in healthy people. And there are domain 3 adipokines. These are maladaptive, pathological adipokines. They promote hypertrophy, promote inflammation, promote fibrosis, and they are anti-natriuretic. They cause renal sodium retention. And these are suppressed in healthy people. Now, just think, if the good adipokines are increased and the bad adipokines are suppressed, that is why healthy people are healthy. In people with visceral adiposity, as visceral mass increases, its biology is transformed. Domain 1 adipokines become markedly suppressed. Domain 3 adipokines become markedly upregulated. Now you have a pro-inflammatory, pro-growth, pro-fibrotic state throughout the entire body. Heart is particularly affected. And there is then another group of adipokines, domain 2 adipokines, which are then brought to the rescue, and they act as a compensation for the loss of domain 1 adipokines and to counteract the domain 3 adipokines. They act just like the domain 1 adipokines, but typically in healthy people, adipose tissue doesn't make them because it doesn't need to. But in patients with adiposity, they're markedly increased in order to maintain some sense of physiologic homeostasis. So I'll give you an example of some of the adipokines. I don't expect any of you to either know much about them or even have heard of them. There are thousands of papers in the literature on this, but each of them has a very special role. So here are domain 1 adipokines. These are cardioprotective. Many of you may have heard of adiponectin. It's the most prominent, but it's not the only one. And the people with HFpEF, people with obesity, have lower levels of these protective adipokines, and the lower the level, the worse the HFpEF and the worse the prognosis. Domain 2 adipokines, these are compensatory, and you can see some of them listed on this slide. If these are increased, people do better because they're doing their job. And means that the patients have less severe HFpEF and a better prognosis. So there are many domain 2 adipokines that have been interesting because they're interesting pharmacological targets. And then there's domain 3 adipokines. These are the evil adipokines. These are the adipokines everyone really, really focuses on. And there are a lot of them. Some of these entries don't represent single molecules. They represent families of molecules. And the higher the level, the more severe the HFpEF, the worse the prognosis. And it has, these are uniformly increased in both experimental and clinical obesity. You can measure them in the bloodstream. You can measure them in individual organs as well. So you might say, well, it's a nice story. Well, what's the evidence that this actually happens? Well, we can produce HFpEF experimentally, pretty easy to do. You take a mouse and you overfeed them. Give them a high-fat diet, or what some people call a Western diet, sort of speaks for itself. And they become obese. Some of them, fat mice become really big. And they develop HFpEF. If you want, you can put an accelerant on it. You can either anything that would increase blood pressure would accelerate this, but you don't need an accelerant. If you just wait long enough, the mouse will develop HFpEF just from obesity. And what investigators have done is something really remarkable. What they've done is they've taken these obese mice and they have focused on one signaling molecule to see if one molecule, one adipokine, all by itself could represent a central role in this cascade. So I'm going to be talking about 2 of them. One is platelet-derived growth factor D. If you feed a mouse, they become obese. They develop HFpEF. They develop left ventricular hypertrophy, fibrosis. And if you measure this adipokine, platelet-derived growth factor D, it is increased, not in the heart, not in the kidney, not in the brain. It is increased only in adipose tissue. And what they did was amazing. They then manipulated the mice to silence the expression of this one adipokine only in adipose tissue. Only in adipose tissue. And when they did that, the mice didn't develop HFpEF. So this is high-fat diet, obese mouse, increased levels of one adipokine. You know it's coming from adipose tissue because it's the only tissue expressing it. You knock it out only in adipose tissue, and the mouse doesn't develop HFpEF, indicating there is a communication between adipose tissue and the heart based on this single molecule. You might say, well, they sort of got lucky. So let's take a look at another adipokine. This is autotaxin, another high-fat mouse diet developing HFpEF, developing hypertrophy, fibrosis, and would you not be surprised to see that autotaxin levels were increased only in adipose tissue, nowhere else? And when autotaxin was silenced only in adipose tissue, not any other organ, the mouse didn't develop hypertrophy, didn't develop fibrosis, didn't develop HFpEF. Recently, Joe Hill and his colleagues did something really remarkable. They did an experiment where they found a single protein that was responsible for the ability of adipose tissue to secrete its products to other organs. Adipose tissue does that either through its membrane or most commonly through vesicles that form on the cell surface. And these vesicles are sort of messenger pockets, and they travel through the bloodstream, and they're picked up by other organs. And so Joe found that there was a single protein that was responsible for these vesicles actually being formed. These vesicles contain dozens, hundreds of adipokines. And he found when he fed a mouse a high-fat diet and they developed HFpEF, they made a lot more vesicles. And when he knocked out the protein, so they didn't make vesicles, the rats didn't develop HFpEF. So time and time and time again, it's been done now for a dozen different adipokines. If you knock out the adipokine only in adipose tissue, then the mouse does not develop HFpEF. So you might say, well, I like mice, but I don't treat mice. So why should I care? Well, HFpEF is an unbelievably common disorder, progressive disorder, disabling disorder, lethal disorder. We currently have two broad-based treatments for HFpEF, SGLT2 inhibitors and mineralocorticoid receptor agonists, antagonists, finerenone specifically. And these drugs are thought to act in a variety of different ways, and there's lots of controversy and discussion about what their mechanism of action is. But the mechanism I thought was the most interesting was both of these drugs produce a marked decrease in visceral fat mass. And they change the biology of fat. And they increase the good adipokines, decrease the bad adipokines. Could that be responsible for their benefits in HFpEF? Well, maybe. Maybe not. What is interesting is that if you measure the amount of adiposity, you actually can predict the magnitude of the effect of these drugs in patients with HFpEF in clinical trials. But there's more striking evidence. The two most obvious ways of reducing fat mass is by bariatric surgery or incretin drugs. Now, everyone knows they cause weight loss. Everyone knows they alleviate obesity. They disproportionately alleviate visceral adiposity. And they increase domain 1 adipokines, decrease domain 3 adipokines, and patients have a markedly reduced risk of HFpEF with the use of these drugs. You might say, well, these are weight loss drugs, and the patients have obesity. And I mean, really? Is it a HFpEF effect? Well, this is a really interesting trial. This is the SOUL trial. It's a trial of oral semaglutide, an incretin drug, versus placebo in patients with type 2 diabetes. Now, it's not an obesity trial, but a lot of people in this trial had obesity and visceral adiposity. And they found something really remarkable. They reduced the risk of heart failure, but not heart failure with a reduced ejection fraction. Only heart failure with a preserved ejection fraction. A 41% reduction in the risk of HFpEF, even though body weight in this trial was reduced only by 3%, realizing that visceral fat is reduced by this drug 3 to 6 times more than the reduction in body weight. So it's a striking effect, and another reinforcement of the fact that we can actually not only treat HFpEF, we can prevent HFpEF by targeting adiposity. Now, again, most people have thought, well, this is really nice and gee, it's a great story. But we've heard many great stories in our lifetime. I mean, is it a true story? And one would say, well, what do you need to believe? Well, we have epidemiological associations. We have causal inference from Mendelian randomization studies, causal inference from experimental studies that I've already reviewed. We have translational support with SGLT2 inhibitors, mineralocorticoid receptor antagonists, and GLP-1 drugs. And it's nice. It makes a great story. But here's the most important missing piece. Most important missing piece is show me that you can target one adipokine in patients without losing weight, and that the drug only targets that adipokine, and show me that it benefits HFpEF. Well, that would take normally about 15 to 20 years. Except I got lucky. There is a drug like this. It falls into the domain 3 adipokines. One of the domain 3 adipokines are adipokines that signal through activin type 2 receptors. The classic agonist is activin A. And there is a drug that is an activin type 2 receptor ligand trap. Basically sucks in all of the agonists for activin type 2 receptors. Therefore, it's sort of simple, in the simple term, act as an activin antagonist. And only for activin type 2 receptors. So this is a great example of an adipokine antagonist that would never, ever, ever be developed for HFpEF on its own without a rationale for doing it. Well, there was a rationale experimentally. Someone actually did an experimental model in HFpEF. And in two different types of HFpEF showed that sotatercept prevented left ventricular hypertrophy, prevented left ventricular fibrosis, prevented the development of HFpEF, but this is a mouse. And you might say, do this in people and predict that you're going to get a result in advance. So the opportunity came when there was interest in looking at patients with HFpEF who had pulmonary arterial hypertension. Now, there's a reason why they looked at people who had both diseases. And the reason is that the sponsor of sotatercept, Merck, had already developed a drug for pulmonary artery disease. It was approved, used, outrageously expensive. But that was in people who had structural vascular disease and didn't have HFpEF. So Merck said, well, maybe we should look at it in people who have structural vascular disease and who also have HFpEF and see what happens. Now, there's a real problem in doing this. This has been done before, and it has failed miserably. Two drugs, one an endothelin antagonist, macitensin, and one is a PDE5 inhibitor, tadalafil, and both of these drugs had a great effect on the pulmonary vasculature, and pulmonary vascular resistance went down. Blood flow across the pulmonary artery went up. So the right heart was now able to push blood into the left heart, but the left heart pressures were elevated because of HFpEF, and the patients went into worsening heart failure. Wedge pressure went up, worsening heart failure events. Exactly what was predicted, because here you're allowing more blood to cross into the left heart, flooding the left heart. But Merck said, well, maybe we should try it anyway. And I had heard about their trial, and I said, I think their trial is going to work out differently. I think that their drug is going to reduce structural pulmonary vascular disease, but I think it will not produce worsening events. It will not increase wedge pressure, even though it increases transpulmonary blood flow, because these patients, because activin A is being inhibited, their HFpEF will get better and their wedge pressures will go down and they will have fewer events, even though their transpulmonary blood flow will increase. I think most people thought I was a little crazy. The people who were interested in pulmonary hypertension were really interested in the right side, but not terribly interested in the left. And here's what the results look like. Wedge pressure didn't go up. Wedge pressure went down. It's a double-blind, placebo-controlled trial just published in Circulation 2 weeks ago. And wedge pressure went down. Not only did wedge pressure go down, left atrial volume decreased strikingly. It's one of the largest decreases in left atrial volume we have seen. And look at the worsening heart failure events, a dramatic decrease in the risk of worsening heart failure events with sotatercept in people with HFpEF in this trial called the Cadence trial. So what happened here is that although transpulmonary blood flow went up, wedge pressure went down, left atrial volume went down because HFpEF got better simply because of the antagonism of a single domain 3 adipokine. And what was most remarkable in this trial was that all of these benefits occurred even though this drug increases blood pressure. And an increase in blood pressure would expect to adversely affect the left heart. And the opposite was seen. So this effect on the left heart was powerful enough to overcome an increase in transpulmonary blood flow and an increase in systolic blood pressure. So this actually, just fascinating, is the first prospective validation of the adipokine hypothesis based on a single targeted adipokine, a drug targeting one adipokine in patients with HFpEF. We are now strong advocates for them to look at a general population of patients with HFpEF, whether they have pulmonary hypertension or not. We don't think it should matter one bit. We hope to persuade the sponsor. We may or may not succeed, but we now have one additional piece of evidence to support the adipokine hypothesis. And we have so many other drugs that have been developed as adipokine modulators. These are not drugs that are hypothetical. These are drugs actually in the clinical setting, all of which modulate adipokines. And every time I make up this slide, I always add a few more, and there's no room left. It's an incredibly hot topic because it has so many public health implications. Just think about it. Just suppose you could prevent the adverse consequences of obesity without weight loss. Just suppose you could prevent the adverse consequences of obesity because you prevent the maladaptive molecules that adipose tissue makes. That is a profound change in the way that we think about this disease. So there is a unifying hypothesis for heart failure with a reduced ejection fraction related to neurohormonal imbalances. I think there's a similar hypothesis for heart failure with a preserved ejection fraction based on adipokine imbalances. The amount of work that's now being done in this direction is so encouraging. It's so encouraging because for 20 years, the field of HFpEF was marked by 30 to 50 failed trials. One idea after another failed. Now we have 2 broad-based therapies, a third on the horizon, with many more to come. Thank you so much.
No. Stay up here, Dr. Pachter. I like the way you teach. It is really enlightening, and I think the way in which you set out your first objective was to make us think was really successful today. I do have a question, though, for you to sort of bring it back down to earth. Given the prevalence of HFpEF and the importance, given a safety net hospital, which we participate in, and the limitations that we have for these three interventions that you mentioned, which really are out of reach for most of our patients. What is your recommendation for how we manage these patients today?
Are you asking me to fix our healthcare system or to explain HFpEF?
You can't. I don't think you can certainly do the second. I'm sure about that. But how do we treat our patients today, given the limitations that we have?
Well, we do have SGLT2 inhibitors and incretin drugs. They work.
Expensive.
Yeah, they are. Dapagliflozin is going off patent this year. It will become generic. By the way, just because it becomes generic doesn't mean it will be cheaper. We have the most expensive and most ineffective healthcare system on the planet. We have an ability to come up with great ideas, develop wonderful drugs, prove they work, and deliver them to no one. And if you had a little bit more time, I would not be able to solve anything more.
Thank you. Hold on. Dr. Hare.
Milton, thank you so much for being here. I was at a 1992 lecture you gave on the neurohormonal hypothesis that was incredibly influential, only to be rivaled by this. But I have a very simple question. Given the overlapping pathophysiology between the Adipokine hypothesis and the neurohormonal hypothesis, why do patients with this pathophysiology not get a remodeled ventricle and a low ejection fraction?
Oh, wow. That is a wonderful question. First of all, I'm not, I think there is an overlap, but I'm not certain how big. I think there's a group of patients who have what we call mildly reduced ejection fraction, who have obesity, in which both models apply. I think the vast majority of people with really low ejection fractions really don't have a lot of obesity. And so for the on the continuum, the ones all the way on the left and right, I think, are reasonably distinct. But you're really asking a much more fundamental question, which is if obesity creates adipokine imbalances and they are harmful to the heart, wouldn't they be harmful in someone with heart failure and a reduced ejection fraction? Now, these drugs have never, ever been tested in people with heart failure and reduced ejection fraction, except in 2 small trials where the incretin drugs really turned out reasonably badly because they increase heart rate. And in HFrEF, that's not such a great thing. But we can get no sponsorship for an obesity trial in HFrEF. There are no takers. No one is writing a check. Everyone can write a protocol in 24 hours. No one can execute it. So there are a lot of people where we don't know. But maybe the safer approach wouldn't be to go the incretin route because of the increase in heart rate. A safer approach would be an adipokine-specific targeting. Merck is discussing the possibility, they make sotatercept, of doing a pulmonary arterial hypertension trial in HFrEF. And that would be interesting.
Sorry, Dr. Dunn, someone else.
Oh, I'm sorry. My name is Dr. Martinez. Thank you for your lecture. I'm wondering, what's your take on epicardial adipose fat?
I love epicardial adipose fat. So just think about this. So the visceral fat is any fat around major organs. The fat around the heart has two components. One is typically referred to as epicardial fat. The other one's called pericardial fat. They're supposed to be separated by the pericardium. Epicardial fat is so intertwined with the heart that there's no fascial plane and they share an unobstructed microcirculation. So anything that epicardial adipose tissue makes will be transmitted to the heart. Typically, in a healthy person, epicardial adipose tissue is a single row of benign-looking cells. And people with adiposity, it becomes markedly thickened, inflamed, changes its biological profile. By the way, makes an enormous amount of activin A. It really does. It's amazing. And so I think that when we talk about the effects of these drugs, it's not just the endocrine effects, it's the paracrine effects that really make a difference. Now, here's the problem. Just suppose you and I believed in what we just said. I do too. How do we prove that in a person? In a person. So you might say, well, we'll measure epicardial adipose tissue volume. And we can do that. We did that in the SUMMIT trial with tirzepatide. We used cardiac magnetic resonance imaging. Patients have got markedly better. They lost weight. Everything got better. Epicardial fat didn't change. Why? Because CMR measures mass. It doesn't measure biology. So the right way would be use CT. And CT with fat attenuation would show you that the biology had changed and that the whole, the expectation is sotatercept here would actually make the biology revert to normal, changing the fat attenuation on CT. And, you know, I'm waiting for someone to do that study because it can be done in 30 patients and we would have an answer. You know, we'll see how everything works. But what's nice about it is the number of the amount of capital that's going in as investments here is so enormous that if one company doesn't do it, another company or 5 companies will. So it is, you know, I'm amazed by how much energy and resources there are now to test this hypothesis.
Thank you, Dr. Pachter. Thank you all for coming. I want to thank the Lemberg family specifically for sponsoring today's lecture. Those of you that have questions on the line and in person, please come up after the lecture. I want to remind everybody the MEC and MOC credits are on the QR code as you exit or on the chat. And we have a presentation of appreciation to Dr. Pachter. I want to thank everybody again for coming. See you next week.